Good morning. Welcome to Structural Heart Live Cases from the Mount Sinai Hospital in New York City. I'm Matthew Williams, your moderator from NYU Langone, also in New York City. We have a very exciting case for you today. If you'd like to be able to view this on your iPhone without an internet connection, you may go to the Apple App Store and look for CCVVC. The video of this broadcast will be available from the website later this week, and the last broadcast from June is available now in the archives. We'd love to hear your questions, so please email us at info@structuralheartlivecases.org. Well, I'm very excited for this case, and I'd like to introduce our operators today. We have Drs. Kinney, Sharma, and Ani. Let's go to the lab.
All right, Matt, thank you and welcome, and of course welcome to our viewers of the structuralheartlivecases.org. And the continuation, this is our case number 6 actually. We do every 2 months, while we do a coronary every month and a peripheral every month now. And we're glad to be that you are here as a moderator, and we actually have my team, Dr. Kinney on the left side, Dr. Kovacic on the right side, and Ani Anwani in the back, and of course with my fellow. We have now the structural heart disease fellow, Asad, here. So key is that we just go through as usual, first present the case and the case history, and then of course go through some technical aspects, and then live performance of the case, followed by a discussion about one point with the 10-12 slides. Now with that note, I think we can get our first slide ready. These are the supporters. Next. These are our individual disclosures. Next. Now this is a 88-year-old female who was admitted last month with heart failure, and of course we knew that she had aortic stenosis and has a severe AS, and at that time underwent balloon valvuloplasty. Echo consistent even after valvuloplasty a few weeks later with a severe aortic stenosis, which will go in little detail later. And of course Partho Gupta will tell us what is the status of the AS now. Patient has a non-obstructive CAD and had mild hypertension. Next. And basically these are the various other non-invasive testings and the risk score. CT angio again will go in details in terms of the vascular dimensions, and STS risk mortality is 5.15 with the Euroscore mortality of 12.81. Patient was determined to be extreme risk. All these cases, like everywhere else, has a heart team discussion. We have a TAVR meeting every Monday, and of course these patients all seen by a cardiothoracic surgeon, and Ani Anwani saw this patient and felt extreme risk for surgical AVR due to advanced age and marked generalized frailty. Patient is planned for CoreValve Evolut R TAVR with a percutaneous femoral access. Initially we thought with the conscious sedation, but then in the history came out to be patient has a large Zenker's diverticulum. So so that it does not have any aspiration, they had to put a special tube in the esophagus, so patient has been intubated. Next, and I'll leave this one now. Here Partho, who is our structural heart echocardiographer director, under his assistance, I would say that our TAVR results have been phenomenal. So Partho, tell us about what's going on in this case.
Thank you, Dr. Sharma. So the team back here consists of the cardiac anesthesiologist. We have Dr. Benji Salter, and along with him his fellow, Josh Heller, and my fellow, Amir Ahmadi. So what you're seeing on the screen right now is the transesophageal echocardiography. The patient continues to have severe aortic stenosis. You can see their color flow showing restricted leaflet motion, and also what you see on here is the you can see the left main coronary artery, which is flowing very well. This is the long axis view. You can see the restricted leaflet motion. There is considerable amount of calcification in the leaflets, and I will show you some more images. There is mild aortic regurgitation. And when we perform a 3D analysis, you are able to see not only the amount of calcification. You can see here there is a lot of calcification on the leaflet. This is the right coronary cusp, and then you can see here the annulus. There is a mass of calcification at the annulus, right at the annulus. Meticulously performed 3D transesophageal echo is revealed perimeters, and all the details are available here. Perimeter of 6.6, area of 3.4, and the two diameters of 2.4 and 1.8. You might see a little bit of discrepancy with the CD because of the amount of calcification and the calcific shadowing that is encountered. But nevertheless, this is extremely important. The dynamic image is revealing that there is a lot of calcium, and this information is important when we are doing the balloon dilatations. And then we have confirmed the left main distance. This will be also shown on the CT scan, which is about 1.9 centimeters from the takeoff. The left ventricular function is normal. You can see here mild to moderate concentric left ventricular hypertrophy, preserved LV ejection fraction, mild aortic regurgitation, a mild mitral regurgitation. And so we know that the information has been conveyed, and that will be useful for deciding the strategies for the interventions.
Good. Now, knowing that all these cases are calcific, but anything which we need to worry about, because sometimes you warn us that it's an extreme calcium which could cause annulus rupture or going into the aorta and so on and so forth. Anything we need to especially worry? And what are those cases?
So this patient has moderate to a severe amount of leaflet calcification. This is typical. The only thing that is worrisome is that there is a calcific mass at the annulus. So we have to be careful about the strategies of post-TAVR placement, balloon dilatation. We might be not very generous with or oversize the balloon very carefully if need be. We may buy in a little bit of aortic regurgitation and decide the risk and benefits of balloon dilatation. So there might be a little bit of aortic regurgitation that might happen, and so the strategies for balloon dilatation may depend upon the safety. So that's important to know.
Very good. Okay, we go back to our slides now, and now we next. Good. Next. Now we JK will talk about our annulus measurement with the CT.
Sure.
And
Thanks,
this is
Dr.
very important because that's really the size. I would say that compared to the earlier studies where echo was considered as the determining factor that which valve to use, the CT now has usually become the gold standard, where which we do based on the annulus and perimeter, that what valve to select. And this is now JK will take us through the CT findings.
Sure. Thanks, Dr. Sharma. So you can see there the annular measurements we've got, both the perimeter and the mean maximum diameters. The short axis is about 18.7 millimeters, the long axis 24.7 millimeters, giving us a mean of 21.7 millimeters for the annular diameter. Perimeter we got at almost 70 millimeters, 69.9 there you can see, in an area of 3.8. So a little bit higher than what we got by the echo. And interestingly of note, while there's no question as we saw on the echo, there's very heavy leaflet calcification. In the true annular plane we're seeing there, the actual calcification in the annulus is actually not too bad, or there's almost none that we can see there. There's severe calcification involved with the valve in general, but not specifically the annular plane level. Next slide. So just to take you through some other relevant measurements here, the angle, which is important for how coaxial the valve is going to sit when we're sitting across the annulus, is 47 degrees, which is reasonable, nothing too severe here. Next slide. The sinus of Valsalva diameter, the mean diameter is 28.1. You can see there's significant difference between the three sinus of Valsalva measurements, which is normal, but a mean of 28.1, which is quite adequate for the 26 Evolut R valve. Sinotubular junction height is 22.5, ascending aorta diameter 30.3 millimeters. All very appropriate for this valve size. Next slide. You can see here on echo, Patho got 19 millimeters for the left main height above the annular plane. I got 18.5 millimeters for the left main above the annular plane. Right coronary 17.5. Very high coronary ostia, so we're not concerned in this case about coronary ostial occlusion. Next slide.
What is, just for understanding, what is the number where we need to worry about height of the coronary ostia, and is it different for the core valve versus Edward?
It's a very good point. So around 12 millimeters we start to get concerned about the left main or the coronaries being low, and the equation is actually more than just the height. It also includes the length of the left cusp of the aortic valve, and whether the length of that cusp is 4 millimeters or more than the height of the left main above the coronary plane. Also of relevance is particularly with the Evolut and CoreValve systems is the sinus of Valsalva dimensions. And if they're generous, we're less concerned about left main occlusion than if the sinuses are very small for the valve size. Today we need, for a 26 valve, we need 27 millimeters of the sinus of Valsalva. We have 28.1, so we're comfortable there with our sinus of Valsalva size.
Okay.
To then take you through the axis planning, this is a 3D reconstruction of the axis. You can see there reasonably straight vessels in a lateral plane, but there's a fair bit of AP tortuosity, but really mild calcification overall. Next slide. No, you went backwards, go forwards. You can see here common iliac dimensions about 6 to 7 millimeters bilaterally, a little bit of mild calcification. External iliac 7 to 8 millimeters. Next slide. And you can see here, just to specifically take you through the access point, high in the common femorals on the right looked quite reasonable at about 8 millimeters. The left, you can see they're a little bit diseased, a little bit smaller. And in the mid-common femoral, there's a big spike of calcium sitting in the right side. So we specifically accessed fairly high on the right side in that point up there, and you can see in the top left of the screen where it's free of calcification and a nice size. So next slide. So these are the sizing charts for the Evolut R valve. You can see our patient down in the bottom in yellow, 21.7 millimeters mean annular diameter, 69.9 circumference, other measurements there. All measurements fitting cleanly within the 26 millimeter sizing for an Evolut R valve. Next slide.
Okay. This basically puts it together that we are using the Evolut R, which is the new generation of the Medtronic core valve, and big advantage of the valve is it's a much lower profile, and it's a 14 French compatible. Next. And these are the, as you know, that the new valves now will, except the 31 millimeter, all will be the Evolut R. And of course, the sizing remains about the same. But the key is that now you need only 5 millimeter of the femoral artery.
5 millimeters.
Right, that's the key compared to a 6+, so that more and more patients now, iliofemoral, which is done in about 75–76% of cases. Until now, that number, in my opinion, will go to almost 90% soon. Next. Yeah, and this is the whole system, those who have been using it. Next. The more important is that there is some difference in terms of deployment and where the markers are, and we'll go through that during our process. And clearly, that the valve itself, as actually Anu mentioned, it looks very clean. Maybe sometimes we cannot define exactly what it means, but clearly by holding the valve itself as well as the deployment and the angiographic pictures comes up, looks quite good. Next. And the key is there is a whole science behind how you load it up. Next. And is it correctly loaded or misloaded? And of course, these are the very subtle points, but they are very important for overall functionality of the valve. Next. And then of course, this basically puts it now to the next level. I would say for the core valve point of view, that best practice with the low profile, with the 5 vessels, 5 millimeter size up to vessels, and good placement. And you'll see it compared to our earlier valve generations of the core valve, it really stays there. And of course, you can always recapture and position it. And we'll come back to that points during our presentation. Now, as we can go back to Fluoro, now we are ready to, you tell us what you're doing now?
Just crossing it out.
Yeah. So now we have AR2.
Give me AL1. I don't know.
Huh?
Maybe AL1. It's not.
This is the AL1?
No, AR2.
Okay. Yeah, AR2, trying to using a straight wire. So while we are getting it, I'll ask from Ani. Ani, you saw the patient. Any question for this patient having a TAVR?
No, not really. She is almost 90 years old and she's very frail, elderly female. So she's not the kind of patient that would have had a valve replacement even 10 years ago in the pre-TAVR era. So she's not a surgical candidate. So she's the kind of patient that would have gone into the Partner B cohort.
Yes. Perfect. Now, Matt, you can comment also. Now I know that you are the PI for the Evolut R trial, that how the valve is working, because we do have some experience. We have done about what, 8 or 10 cases. What is your experience with the Evolut versus our conventional core valve?
Sure, yeah, we've had a very positive experience with this valve. I think we've done about 50 of them at this point. We don't have the US data available, though the enrollment has completed, but when we look at the data from Europe, granted it was a small series, about 60 patients, we saw a couple big improvements over what we would call now the classic CoreValve system. Obviously one of the biggest concerns is pacemakers, and that rate now is down to in the European trial is actually only 11.7%. So it's a significant improvement. And we also saw less PVL. The amount of moderate or severe PVL was actually less than 5%, with no patients having severe PVL. And this is not direct comparative data, but it's certainly encouraging compared to historic controls. My anecdotal experience, I think, would validate those numbers. We tend to see less PVL, and a lot of this is due to modifications on the frame. The inflow to the frame has been changed to both optimize sealing, but actually decrease the amount of the pacemaker rate, so it's more conformable to the
Previous
annulus.
BAV, that's the problem.
And as you've mentioned, I think the profile is really a big change, and we'll certainly during the procedure we'll get into some of the subtle differences how the deployment occurs, but it's different how the valve self-centers, and also at the end of the day, as you know, one of the big advantages to this system is that you can recapture it. So if you find that you're too deep, too low, you have the wrong size, various issues that you can obviously recapture the device, reposition it to really optimize the outcomes. So are there any specific factors with this patient that you would choose, say, Evolut over SAPIEN 3 or another system? I think it was an excellent choice.
Right. We know, actually, the SAPIEN 3 for us, we don't have access to it yet. But the key is that, I say that you need to do things which you get good at it and keep doing it. The same way that actually at Sinai, majority of cases are done with the Medtronic CoreValve and now of course Evolut, but some cases maybe at the size, if we worry about the septal hypertrophy or the height of the coronary ostia, maybe decide one versus the other, but otherwise want to go with the lowest profile and what you work with the best. And so what I also found clearly with the Evolut is that it's just that very predictable in terms of where the position is. So if you have it 4 millimeter below, and so it will just stay there. So I think to me one of the great advantage which they have done with the sheath and so is that it really stays at the position wherever you have decided. So and that's a great advantage. Remember, many times CoreValve you started with a good position, but by the time you release it has gone above or below. But with this, with the Evolut, actually, that's a very important distinction.
Yeah, I think that's an excellent point, because the technology modifications they made to make the system actually recapturable added stability to the system. So I think you're absolutely correct that it tends not to move as much. It also tends to self-center a little bit more. Now this patient, obviously recently had a valvuloplasty. And so I agree not to pre-DIL. What would be your standard practice if, say, this patient had not had a previous valvuloplasty?
We actually do quite a bit of pre-dilatation, and idea is that try to avoid the
Catheter, submitral?
Give us a try if possible. Yeah. Okay.
Mitral.
Well, let's connect first for the pressure. Yeah. We tried, if possible, decrease the post-valve post dilatation, but we are very aggressive and try to do as much majority of the time. Very rarely we'll skip it, and particularly now things may be a little different with the newer design of the present valve. Excuse me. Knowing that that this one is a little easy to manipulate and advance, maybe will decrease. But what is your experience in terms of the pre-dilatation?
So I typically have not been pre-dilating either the classic or the Evolut, but I think there are cases you have to be careful. If you see kind of on a gross assessment that there's very bulky calcification, I think those cases are prudent to pre-dilate to make sure you get maximal expansion of the valve. You can run into a scenario where the valve does not just open optimally, either with the classic or the Evolut system, and that can be a tricky situation. So it's I don't have any hard numbers, but as a general rule, if it's very, very bulky calcification, I'll pre-dilate. Otherwise, I won't. So what wire are you using here?
Yeah, this one is our super
Extra,
stiff,
super
implanter wire, and we avoid the lender twist, which is sometimes get a valve delivered a little better, but really cause, see the valve wire, pull back the wire a little bit, causing little irritation.
No, you're okay.
Yeah, good. And basically, we'll go through this access point of view. JK, you want to? Yeah. Okay, you have already shown it earlier. You want to Sinead? Yeah. Yeah. Good. Now this is the valve which has been loaded. Let's Sinead. Yeah, and turn.
So we're specifically checking for correct loading of the valve.
There you
It's
go.
nice and straight. The paddles are symmetric on the top of the valve.
And as you mentioned, this is an important part of the procedure because as opposed to the classic where the capsule is, you can see through the capsule, here you can't. So this is important to make sure that it's loaded correctly.
slide,
And this
right?
looks great. Looking for the paddles to be in the pockets on the bottom, looking for the system to appear relatively straight, which it does.
Yep. So now this is the valve with the 14 French sheath, which is here. So idea would be that we have 14 French Cook sheath.
Yes.
And idea is that keep it less than 5 millimeter injury to the vessel. So no, somebody has to come there, hold it right, and go through it directly using the 14 French. Now only problem remains is that they definitely need a better design, in my opinion. That if you need to do a post dilatation, because then you are going to put another 14 French sheath or so later on, that can create some hematoma. So at present, this sheath is part of the valve, not detachable. But once they make it, that will be a real addition, so that in the end, when you need to just do a post dilatation, you need not to worry about exchanging the sheath and so.
Hold it now.
So
Sure.
okay, now we go through this the point here, and this is all has to be connected.
We push it.
Yeah.
Hold the wire.
Yep.
Hold
Hold the wire.
Hold the wire. But we should see it above. Remember, very important question is, do you want to see it below or you want to see it above? Because the wire should not move from the ventricle, because if the wire has come out, will be a more difficult. But see the smooth entry of the device. Now you
Yeah.
advance the sheath all the way in.
And I think you need to track this like you did. I mean, it's, you know, hopefully, it usually won't come out. If it does, you can recross. But I think that was the correct way to do it. And
Okay.
then it's important as you come around the arch to watch the nose cone as well, just because there is the durometer difference between the nose cone and the capsule is significant. So sometimes it can separate.
Yes. Okay.
But you flew across there. That's great.
Good.
Pigtail.
I got one, I think. Right?
Position the pigtail again.
No, it's good.
You're okay.
Little crane.
Yeah. You
Oh,
need to
I'll
go
do-
to
I'll do-
cranial or caudal?
Little quarter. We just move we just align so we're coaxial to the valve here,
Yeah.
so nice and coaxial.
Okay, you will take us through the steps now, what you will be doing.
Okay. Let's see the positioning now.
Good.
It's about 6 millimeter.
Mm-hmm.
Let's go, Sinai, okay? Inject.
And that's another
think
point that
looks
compared
okay.
to the core valve, the marker band is further inside, because that's the sheath outside. So it's inside there. So that's, and the last diamond or first diamond is 12 millimeter, means 6.5 compared to 4 millimeter. So we are a good position.
You have a good position. Start now, Ani.
Okay, so just start releasing.
Yeah, I think you're at a good depth. I mean, there's I think with this system, there's no reason to aim for the 2s and 1s that we tried to with the old system. So
I think so far so good. Yeah. Okay. Sinai again. Okay.
and you'll notice
Okay. Keep
that
releasing.
the system is responsive in a one-to-one fashion.
Yes.
So as he turns the dial, it moves.
Can you
You
pull
know,
your
really
T
one-to-one.
up?
Yeah.
Releasing. Yeah.
Yeah,
and
that's
pull.
also very important, that it's a one-to-one, the response. They actually have done all what we do in coronary intervention. That your
Exactly.
stent you advance and it stays there wherever you need to move, and
Section
wire tip.
rotation.
Okay.
This has
Sinai
done a
again.
tremendous job.
Great.
Okay.
Everybody agrees?
That's
Looks good?
Start pacing.
Okay, what speed?
120 pace.
Okay.
Okay, keep releasing now.
It's just staying very stable.
Okay, stop pacing.
So you
60.
see that line as it's approaching the paddle pockets where it is now.
Okay,
You need
see
to,
now.
if you take that line beyond there, it's really the point of no return
good.
in terms of recapturability. So there's a little warning
Release now.
track that you hear. You hear kind of a noise. You go a little beyond that and then stop as you've stopped here.
At this point, if we are not happy, we could recapture it and position it. But clearly now we are. It looks like everybody happy with the position, and we
Position, yeah.
release it.
Just release.
Okay, Ani.
Okay, we're releasing now.
And you do this nice
That's fine.
controlled
Yeah.
fashion. The paddles always come out, as you see
Yeah.
here.
Separated. Good.
Coming out slowly. Push the wire
Do
forward.
one last max. Okay. Now you bring back here. Let's marry it again.
You want to check the pressure now?
No, but let's marry this one first.
Can you
Okay.
show
No, no,
me?
no.
Yeah,
Okay.
show me.
Good.
Mhm.
Okay.
Okay. Now this we are going to just bring it below. We don't need. We leave it still. Good. And let's go with the.
No, if you want to check the pressure, right?
Yeah. How can we check the pressure from this catheter?
Now we have to go in LV with this one.
You can check it as long as you don't. If the capsule is not married to
Yeah.
the inline
check
sheath,
it.
there's a little gap. You can transduce the pressure through it.
Transduce off the sheath.
You don't
Oh, it's
bring
off the
it back
sheath.
so that you have the sheath not at the
Okay.
end.
Just leave it at
Capsule is
60
married.
for now.
Yeah.
Okay, then turn it off.
All right, so
And how's your rhythm now? Are there any changes?
No, just still using pacemaker at 60.
How does it look, Partho?
so the valve on the TEE looks underexpanded, and
Oh.
you can see if the echo is up, that there is a gap that
22
you can
Zimmer.
see, and there is moderate
was 21.
paravalvular regurgitation.
You want to do a
You want to do aortogram?
yeah.
Yep, ready.
Okay, ready for aortogram.
Go.
Inject. Yeah.
Yeah,
Oh.
quite a bit of air.
Yes.
Okay.
Now
Let's
we
hope
have to change.
we need a 14 French sheath again.
Yep, there it is.
This is the one. Okay. So we have to hold.
Yeah.
Asad, you go there.
So
Okay,
what will you post still with here?
Yes. So,
So
we'll
the-
use
yeah.
at 22 or what do you
So
want?
the mean diameter was 21.7, so we'll go with the 22 ZMed balloon.
Hold it.
And do you ever use a true balloon?
We do at times, absolutely.
Coronary is up.
And we go backwards and forwards between them. There's pros and cons, I think, with both balloons.
Sure.
I like actually true balloon quite a bit.
I mean, this your annulus here it doesn't have high risk features for rupture, so I think you probably fine with either system.
Agreed.
Hold her. Yeah.
Good. So now we have put a 14 French sheath again.
Flush.
Yeah. This step is the one, in my opinion, I am worried about. That this change, if you in the end may cause some hematoma, because now patient is fully anticoagulated. You don't have a good grasp of it, and I'm sure sometimes may even break some pre-closure. No.
No,
It
I
could.
think if you, I mean, of course, the more
I mean-
exchanges we do, the more chance we're going to have of causing complications in the groin. I think that's definite. But if we can minimize that and keep it to just
So we'll
Okay.
talk to Medtronic people. They change it, just make the sheath
mag.
detachable. Yeah, look.
Who has the? Yeah, can you pull your TE?
Yeah.
Okay.
One magnification.
Pacing at 180. Okay.
Okay. How are you doing? We are good? Okay.
Okay. Start pacing. Okay. Go.
Good capture.
Yeah.
Do little syringe.
Yeah. Go with the syringe. Continue pacing. Continue pacing.
that'll come out. Okay, that'll come
Continue
out.
pacing. Continue pacing. Okay. At 60.
Good.
Stop at 60.
Yeah, that's
get
one of the nice
patient-
things about the True. You don't have to boost it like you do there.
exactly
but-
with this syringe.
Much improved. So now this just a wire-related transvalvular AI, but the paravalvular is markedly
It's fantastic.
reduced, just trivial.
I mean, clearly that putting an additional the material up to the tip, that skirt, really covering the distal part of the diamond will decrease some paravalvular regurgitation. And that actually has been our anecdotal experience also, although it still need to be proven.
That's a great result. I'd like to remind people, if you have any questions, please email at
Just smile.
info@structuralheartlivecases.org. Yeah, that looks really great, and we still, like the classic system, we would still expect some continued expansion of the system, and
This
you
one.
know, what trivial amount remains may even have some improvement.
What do you want to do? Two close to each other.
Okay, let's see. There is a hemodynamics point of view. Diastolic pressure about 70. There is no gradient. We can just show the tracing of the hemodynamics.
Pull this out.
Guys, can you show? Guys,
Yeah,
you-
good. Done. Very good.
We see it. It's great.
change the view a little bit.
Yeah, good.
Okay,
Okay, now
ready
we
for
are
the
ready.
aortogram?
Yep. All right. So 1+, which is okay. Mild, clears up with the second beat, nicely about 4 millimeter position below, and the pacemaker point of view is still, although patient requiring
No, it's sinus with a new. There's a new bundle, but it's still sinus rhythm.
your sinus with a new left bundle.
Okay.
Yes. But clearly no gradient from the procedural point of view. We are done. And JK, what will be your vascular issues now?
So now we'll carefully close the access. We don't go up and I haven't been going up and over anymore from the contralateral side with a safety wire. So this will just be a straight closure over a wire with a couple of DSA shots on the way out. And I'll do that now, and we'll show you before we finish the transmission.
Now, how long will you leave the pacer in this patient, assuming they don't develop heart block? So new bundle, say the PR stays acceptable.
Well, actually, you know what? We need to learn from you what is your practice. We are still routinely leaving 48 hours. Some cases we are removing next day, but that definitely is affecting our length of stay and the CCU need. I know that some people have developed those fast track protocol that you could take the pacemaker out same evening, but low risk and where there is no need, no new bundles, and some of them removed next day. So we rare cases, I would say maybe 15% we are removed next day, but 85% of cases with the core valve, we are leaving it till for 48 hours.
Yeah.
Now, what is your practice?
You know, I mean, we're getting a number of them out the next day. I think we probably have a little bit of more safety margin with Evolut than we did with the classic system, but it's, you know, it's like everything. You get more aggressive and then you get burned once, and so you rethink how you're going to do it. But if we have patients, any prolonging PR with a bundle, we'll certainly leave it in at least a couple nights. But we've become a little more aggressive about removing them the day after. Certainly, if you know, in some patients where we're a little concerned, we can also leave the sheath in the neck, and so we can get them in quickly
the
if
long
we
J
have
wire.
to refloat one.
Long J wire.
J wire, long.
Now, Anu, you want to say anything with the performance of the valve?
I think they have seen our using the old valve in the last couple of live cases, and this is the new valve. You can see how smooth it is going up, and more important, I think, is the stability of the valve. That I would say that once you have decided this is where you are going to place the valve and you start releasing, it just stays there. I know there is a recapture need for recapture. You know, we've rarely recaptured this valve, but I think great thing about this valve is it is very stable and stays where it is. We used to always say core valve means it makes a dance, because you don't know where you're starting and where it's going to end. You know, and what we do use the word is the same. It does not dance, and it stays wherever it's supposed to be. And like you have seen, it is a very smooth valve, and most important thing for the valve not to move is the release. The CoreValve which initially came out was the same. The release was so hard, many times we have to go backward, forward, and keep twisting, turning till it's released, and those kind of movements also might have changed the position of the valve. With this, you see that as soon as they're done, release is very fast, and these two things, with the stable valve and the release which happens very fast, I think has made this valve better than the previous valve that had the valve which we have compared to.
Yep.
And I think it's made a much more teachable procedure too because of that.
Absolutely, absolutely. Ani, your comment on this
And
overall?
now for the sheath size.
Yeah.
Yeah, and the other thing is you have better feedback because it's like a one-to-one. You turn the valve, you see what happens. The feedback is instantaneous, which is very good.
Yeah, while on the side, Dr. Kovacic is continuing to do the vascular access. If we can go back for 10 minutes, the point I always try to give the latest data of any one of the publication. Next. And this is basically that the TAVR versus SAVR in the low risk aortic stenosis. The Notion trial just presented in JAC last month. Next. Basically, we know that we have studied both high risk, which is STS of more than 10, or extreme risk, inoperable, in the partner trial. Next. So also in the CoreValve, similar trial design, except there was no standard therapy in the CoreValve. In the extreme risk and high risk, of course, more than 15% incremental STS mortality. So clearly we know that both the trials, the TAVR is equivalent, maybe slightly superior, particularly in the high risk CoreValve trial compared to surgical valve replacement. Next. And then of course 2 trials ongoing, CERTAVI, which includes patients with an intermediate risk between 3 to 10, along with or without CAD, and randomizing same, the TAVI versus surgery, and of course could have a CABG or PCI. Next, and same thing, partner 2 trial, again STS of more than 4, operable, randomizing trial has been completed and expected to be presented next year, and hopefully that will change the landscape of our interventional approach for this aortic stenosis patient. Next. Now basically there are some data that what do you do in the intermediate and low risk group, and that's the key. So there are some data from all patients together. Next, from the Germany, if you see patients based on the various risk, the 1-year data. Next, that if you take all patients, the low risk, intermediate and high risk, not a randomized trial, just from the registry, it basically seems to be that yes, once you go to low risk, you'll have a lower complications, and except the CVA, and this is again goes down to our earlier generation of the Edward valve. Next. Then there was a 3-center comparison of 1-year mortality of the intermediate risk patients. Next, which is propensity match, gave us some data that even in the intermediate risk, the surgery versus TAVR will have a similar outcome. Next. So now we went to the next level, and that is that all comers, the Notion randomized trial, the patients with the low risk. Next, that randomized 280 patients to the TAVR or to the surgery. Next, and you see the mean age 79, and more importantly, STS risk score is 3, 2.9 or 3. So we are talking about the low risk. Remember the intermediate risk, where the partner and CERTAVI will be between 3 or 4 to 8 and 10. So in that group, so those data are still waiting, but we are the first randomized trial in a low risk group, which is less than 3 STS risk score. Next. And these are the various techniques, great success. All were done with a CoreValve, and you see the various sizes of the valves used but about 3% you required more than 1 valve, and very rarely require for surgery in about 2% of cases. Next. And basically what are the data? Next. And that is that look at the all-cause mortality and stroke. The blue line is the TAVR and surgery is in the red. So there's about 2% difference in favor of TAVR at 1 year. So really tells you that even in the low risk group, one thing which we used to worry about, the stroke, kind of has been eliminated. Secondly, probably the less trauma, knowing the percutaneous approach, we did better, although p-value not significant, but numerically, the lower mortality and lower stroke rate with the TAVR group compared to surgery. Next. And of course, these are the individual endpoint with a major life-threatening bleeding and so forth. except the only negative point was the permanent pacemaker. And this was unusually high, 38%. Most of the trials we all know with the core valve is 24, 25%, even pivotal being 22%. But 38% was a little higher, but again, it always happens in different threshold of various centers, but that is what the data are, that clearly high pacemaker rate, but in every way, the TAVR did superior compared to surgical valve replacement. Next. And the functional class was kind of identical once you take it to the class 1 and class 2 at follow-up, both in the surgery as well as the transcatheter. Next. Only negative point was, again, degree of total regurgitation, prosthetic and paraprosthetic, and clearly that patients in the surgery, you have a nice seal, so that patients with the moderate regurgitation is very little, like 1%, compared to the transcatheter TAVR will be about 15%. This is again, knowing that the lot of changes are happening on the TAVR, this may become the moot point after 1 or 2 years with the new designs, that there will be less prosthetic regurgitation, but that is what the data we have at present. But these data did not translate into any mortality disadvantage in the TAVR group, as I showed you earlier. Next. And another big advantage, and you see the valve area, 1.7 with the TAVR and 1.3 with the surgery. And I asked Ani, doesn't it look a little odd that your surgery we could get, and these are the low risk patients that could get only valve area of 1.3?
Well, because the surgical stent occupies part of the orifice, so by definition, you'll always get a relative reduction in valve area compared with a native valve or a catheter valve.
Yeah,
So-
but
so
point
it
is
is-
1.3 in a younger person, like 70-year-old, will be worried 1.3 in
Oh,
an
you mean-
85-year-old.
Yeah, that is what, like if you look at post-surgical series, that's not uncommon.
I see.
Unless you do a root enlargement to get in a bigger valve, say a 23, 25 valve. But if you put in a 21 or less, 1.3 is what we usually see.
I see. Okay.
Yeah.
Well, good. Next. And then, of course, it puts it together that comparable death rates and so next. And there is a very nice editorial. And editorial was well-intended notion ahead of practice. And this is exactly next. And this is what it has done. The top partner in the red and the CoreValve trials. Then in the yellow, partner 1 and CoreValve. And of course, partner 2 and Certavi in a light yellow with a 3 to 8% STS mortality. If the partner 2 is completed, Certavi is ongoing. Hopefully in 2016 we'll have the answer. And now we already do the notion, which is a low risk patient. And again, all these data, if you see clearly that maybe in the beginning a little more CVA in the earlier partner trial, even in the partner 2 and so clearly 2B, which is again using a smaller sheath size of 18 French with a Sapien XT, the CVA rate has already declined. So in my opinion, I don't think we need to worry about the CVA now at present with the present the TAVR design. Next. So if I put it together, our take home message, that notion trial comparing TAVR versus SAVR in low risk AS patient showed a non-statistical trend towards better outcome with TAVR at 1 year with lower stroke and mortality but higher aortic regurgitation. Next. So seems to be TAVR will continue to perform equivalent or superior to surgery in all AS risk group and is expected to soon become the preferred treatment strategy in management of aortic stenosis patient. Now we go with that's what I would say. Let's see, because you know that right now in Germany, I actually had a proctor come to India, they say in Germany, all surgical valve, 75% are being done with the TAVR at present. In Germany is the leader, 75 to 80% are being done with the TAVR at present. Next. So now we go to quick questions. I always try to put 3 questions and we give answer next month, and I'll give you the answer of the last one now. The notion trial comparing TAVR versus SAVR had the mean STS score of 2 to 3, 4 to 6, 7 to 10 or more than 10. Next. Following is the false statement regarding notion trial comparing TAVR versus SAVR at 1 year. Incidence of mortality was lower with TAVR. Incidence of stroke was higher with TAVR. Incidence of AR was higher with TAVR. And incidence of major bleeding was lower with TAVR. Next. And the partner 2A and Certavi trials have included AS patients with following STS risk score: more than 15%, 10 to 15, 4 to 10, and less than 4. Next. And these are the questions of our June questions, 3 of them. If you say the following are the true statement regarding strokes after TAVR, except that most stroke occurs in first 24 hours, delayed strokes are likely due to AFib, Balloon post dilatation has not shown to increase stroke, and major stroke occurs in 4 to 10% of cases with current devices. And you know the false answer is C, because post dilatation has been associated with a higher stroke rate. Next, the following are the true statements regarding silent brain infarct post TAVR, whether it occurs in 50, 75, 75, 95, or 95, and we know that answer is 75 to 95. Next, that is clean TAVI, evaluating Claret embolic protection system versus control. Post TAVR showed all of the following: reduction in new lesions in MRI, reduction in volume of the new lesions, reduction in ataxia, sorry, and higher procedural complication with the device. Answer was that there is no higher procedural complication with the device. With that note, we are here with Jason completing the vascular access.
Show us the fluoro images now. Back to the angiogram. So you can see here what we've done is the first step of getting the sheath out. I've brought the pigtail catheter back to the distal aorta right above the iliac bifurcation and retracted the 14 French sheath just back into the mid-external iliac, taking a DSA shot, still with all the wires in place to check there's no perforation or problem. You can see we're quite good here, no problems. So then we've proceeded to actually close, deploy the 2 pre-closed sutures. So there was 2 pre-closed sutures deployed in the right common femoral artery before we went up with the system. You can see we've closed, still with the wire in place if we need to go back, but nice closure. We've pulled the wire out, and here's our final closure shot. Back to the fluoro, please. Pull the wire out, and you can see there's the final closure shot. Wire out, access point looking very nice, no leak, no problems.
Beautiful. All right, so we are complete from our side. Matt, you conclude now.
Great. Well, thank you, guys. That was just really an excellent result, and you certainly made it look easy. So I want to thank everyone for joining us for this case. Again, this will be available in the archive in a week or so, and the next live case is scheduled for October 13th at 9 a.m. Thank you very much.